We'll start with access. My logic is to where, when, why, and how. I have nothing to disclose with regard to this talk. So really, what is the access? What are our goals? And what must be accomplished? Clinical efficacy in treating an affected area or lesion, and it gets you where you need to be. The aspect of safety, you want to minimize risk and complications, and certainly compatibility with the available endovascular devices and delivery systems. What about initial considerations? Well, you need to identify the procedure and the goal to be achieved. I can't emphasize more the aspect of pre-procedural planning. Clearly, you need to have a good clinical examination. You need to use an optimized non-invasive imaging, and pre-procedural invasive imaging is occasionally helpful, for example, CT evaluation, perhaps beforehand, or ultrasound imaging. Now, device compatibility, it's important that you understand this. Large bore devices obviously require assessment of compatibility, the complication risk, and then closure decisions, because these can be technically challenging. Radial access is now routine for percutaneous coronary interventions and some neurointerventional procedures. There are some issues with device compatibility for both size and the ability to reach the target lesion when we're talking about peripheral cases. Currently, there's a limited device availability for peripheral procedures, particularly in the distal lower extremities, and this can be exacerbated when you're dealing with very tall patients. Well, what are the patient considerations? Body habitus, size of the patient, previous interventions, including the presence of prior stents, grafts, or prior endovascular aortic repair, clearly changes your approach. Tortuosity and the presence of calcification has a significant influence as well. So what about trends in major vascular complications? And you can see over time that in the recent era, this has significantly changed, and certainly the increased utilization of alternative accesses such as radial access has been really an important step in reducing vascular complications. Now, radial access for peripheral procedures has been determined that it's safe, that there is decreased complication rate of radial access versus femoral for PCI. And Kumar et al. Assessed radial access peripheral procedures and demonstrated a very high degree of technical success, 100%, major adverse event rate of only 3.2%, and concluded that it was safe and effective for performing peripheral revascularization procedures. Interestingly, operator safety, Dr. Mirza, who was actually one of my fellows, reviewed outcomes for upper extremity access during fenestrated branch and endovascular aortic repair and found that upper extremity access is associated with higher occupational exposure to radiation. And this was particularly observed with when you use the left brachial approach and some extreme oblique or lateral projections. And while these are often less used, these projections do, however, have implications because they are used, for example, in direct SFA puncture, popliteal, or tibial access. So this is just a case. This was a young woman, interestingly, with Louis-Dietz syndrome, who'd undergone previous operation, presented initially with what was thought to be a femoral popliteal occlusion. She had no femoral pulses, and as you can see, her aorta and aorta bifemoral bypass was totally occluded. So we chose to go through the arm, really, which was the only access site. There you can see the initial wire placement, no flow into the right. We actually, in this case, used lytic therapy and were then able to open up her aortofem bypass and actually ended up stenting her iliac segments. What was interesting about it, what her initial presentation was, an occluded femoral popliteal bypass, which she'd had for a popliteal aneurysm. So now we were limited by access and by the device. So we actually had to go, once we had this open, we were able to go antegrade into the left leg and get our device in place. Retrograde versus antegrade, tortuosity can limit pushability and make delivery difficult. Using either antegrade or retrograde access can improve the mechanical advantage to cross total occlusions or optimize device delivery. Retrograde tibial access does allow for recanalization with re-entry accomplished much more proximally, thereby improving outcomes and allowing for stent placement in some cases. and not uncommonly, both retrograde and antegrade accesses can be complementary. In summary, multiple access sites have been shown to be safe and effective. Assessment of what you want to accomplish and optimal access needs to be planned for. Access sites such as tibial and radial have expanded the options for improved safety and efficacy, and technological advances in devices and delivery systems will allow for increased utilization of these alternative access sites. And I thank you for your attention.